In the 1840s, a surgeon in London performed an operation so catastrophically fast that 3 people died from a single amputation. The patient died of gangrene. The assistant, whose fingers were accidentally severed during the procedure, died of infection. And a spectator, convinced he had been stabbed when the surgeon's blade slashed through his coat, dropped dead from shock right there in the operating theater. It remains the only surgery in recorded history with a 300% mortality rate. The surgeon's name was Robert Liston. And here is the disturbing part. He was considered one of the best in the world. This is the story of Victorian surgery, an era when speed was more important than precision. When surgeons operated in blood-stiffened coats, they never washed. When the operating theater was a public spectacle, and the screams of patients echoed through galleries packed with medical students holding stopwatches. This is the story of how surgery went from butchery to science, how a few determined men fought against ignorance, tradition, and their own colleagues to transform the most dangerous profession in medicine. This is the 300% mortality rate. To understand Victorian surgery, you need to understand one fundamental truth. Before 1846, there was no anesthesia. Every cut, every saw through bone, every probe into flesh, the patient felt everything. They were held down by strong assistants, sometimes tied to the operating table, fully conscious as surgeons worked as fast as humanly possible. Speed was not a preference, it was survival. The longer an operation took, the greater the blood loss, the greater the shock, the greater the chance the patient would simply die on the table from the trauma of what was being done to them. This is why Robert Liston became a legend. Standing 6 feet 2 inches tall, a giant for his era, Liston was known as the fastest knife in the West End. According to medical historian Richard Gordon, he could amputate a leg in 2.5 minutes. Some accounts claim he completed certain amputations in under 30 seconds. His signature move was theatrical. Before each operation, he would turn to the medical students packed into the viewing galleries above and call out, "Time me, gentlemen. Time me." Then he would spring at his patient. Gordon describes him moving like a duelist and begin cutting. To free both hands, he would clasp the bloody knife between his teeth while sawing through bone. But speed came with risks. In one operation, Liston worked so fast that he accidentally amputated his patient's testicles along with the diseased leg. In another, the infamous 300% mortality case, his blade moved so quickly that it severed his assistant's fingers and slashed a spectator's coat. The patient and assistant both died of gangrene in the days following. The spectator, believing he had been stabbed, died of shock on the spot. These were not failures of skill. They were the inevitable consequences of a system that demanded impossible speed, because the alternative, slow, careful surgery, meant certain death from pain and shock. But speed was not the only problem. There was something far more deadly lurking in every operating theater in Europe: infection. In the 1840s, surgeons had no understanding of germ theory. They did not know that bacteria existed, let alone that these invisible organisms could enter wounds and kill patients days after successful operations. What they did know was that patients kept dying, not on the operating table, but in the days and weeks afterward. Fevers would spike, wounds would turn green and foul-smelling. The mortality rate for amputations in major hospitals ranged from 40 to 50%. At some institutions, it was even higher. As one prominent surgeon of the era declared, "A man laid on the operating table in one of our surgical hospitals is exposed to more chance of death than was the English soldier on the field of Waterloo." And here is the horrifying part. Surgeons were making it worse. They operated in old frock coats stiffened with dried blood and pus from previous surgeries. The stiffer the coat, the more experienced the surgeon was considered to be. They used the same instruments on patient after patient without cleaning them. They probed wounds with unwashed fingers. As medical historian Lindsay Fitzharris documents in her book, The Butchering Art, surgeons actually took pride in their filthy operating gowns. Cleanliness was considered unnecessary, even effeminate. The prevailing belief was that laudable pus, thick, creamy discharge from wounds, was a sign of healthy healing, not deadly infection. The operating theaters themselves were nightmares of contamination. Floors were covered in sawdust to absorb blood. The same sawdust was reused day after day. Spectators crowded into galleries, coughing and sneezing over open wounds below. Surgeons moved from autopsies directly to living patients without washing their hands. At St. Bartholomew's Hospital in London, between 1843 and 1859, 41 medical students died after contracting infections in the wards. The very people training to save lives were being killed by the conditions in which they learned. The tragedy is that some doctors suspected the truth. In 1843, American physician Oliver Wendell Holmes suggested that doctors themselves were spreading deadly infections from patient to patient. He was ridiculed. In Vienna, Hungarian doctor Ignaz Semmelweis proved that hand-washing dramatically reduced deaths from childbed fever. He was ignored, mocked, and eventually committed to an asylum, where he died. The medical establishment was not ready to accept that their own practices were killing patients. The first breakthrough came not from cleanliness, but from chemistry. On October 16, 1846, at Massachusetts General Hospital in Boston, a dentist named William Morton demonstrated something that would change medicine forever. He administered ether gas to a patient, rendering him unconscious, while surgeon John Collins Warren removed a tumor from the man's neck. The patient felt nothing. When he awoke, Warren reportedly turned to the stunned audience and declared, "Gentlemen, this is no humbug." News of the Yankee Dodge, as it was dismissively called, spread across the Atlantic. 2 months later, on December 21, 1846, Robert Liston performed the first major surgery under ether anesthesia in Europe. The patient was a butler named Frederick Churchill. His leg needed to be amputated. But unlike every amputation before, Churchill would not feel the saw cutting through his bone. Liston's colleague, Dr. William Squire, administered the ether. Churchill inhaled the gas and lost consciousness. Then, Liston went to work. 25 seconds later, the leg was off. When Churchill awoke a few minutes later, he reportedly asked when the operation was going to begin. The audience erupted in amazement. Liston, the fastest knife in London, looked at the unconscious patient and uttered words that would echo through medical history. "This Yankee Dodge beats mesmerism hollow." Anesthesia was revolutionary. For the first time, surgeons could operate without racing against their patient's agony. They could take their time. They could attempt more complex procedures. They could reach deeper into the body. But there was a terrible irony. With pain removed as a limiting factor, surgeons began performing longer, more invasive operations. And longer operations meant more exposure to the contaminated instruments, the unwashed hands, the bacteria-laden air of the operating theater. The death rate actually increased. This period, roughly 1850 to 1870, became known as the Black Period of surgery. Anesthesia had removed one killer, only to unleash another. Patients no longer died from shock on the table. Instead, they died days later. rotting from infections that surgeons still could not understand or prevent. The answer came from an unlikely source, a French chemist studying why wine went sour. Louis Pasteur had been investigating fermentation, the process by which grape juice becomes wine. Through meticulous experiments, he proved that fermentation wasn't a spontaneous chemical reaction. It was caused by living microorganisms, tiny creatures, invisible to the naked eye, that floated in the air and landed on organic matter. Pasteur published his findings in the early 1860s, and in Glasgow, Scotland, a surgeon named Joseph Lister read them with growing excitement. Lister had been struggling with the same problem as every surgeon of his era. In his male accident ward at Glasgow Royal Infirmary, between 45 and 50% of amputation patients died from infection between 1861 and 1865. He had tried everything: better ventilation, cleaner wards, different dressings. Nothing worked. But Pasteur's germ theory offered a new explanation. What if wound infection wasn't caused by bad air or spontaneous corruption? What if it was caused by the same invisible organisms that turned wine into vinegar? If germs caused infection, Lister reasoned, then killing the germs should prevent infection. He needed a chemical that could destroy microorganisms without destroying living tissue. He found it in an unlikely place, the sewers of Carlisle. Carbolic acid, a coal tar derivative, was being used to reduce the stench of sewage. Lister learned that it had also been used to treat parasitic infections in cattle. He decided to try it on surgical wounds. On August 12, 1865, Lister treated an 11-year-old boy named James Greenlees, who had been run over by a cart and suffered a compound fracture of the leg. Compound fractures, where the bone pierces the skin, were almost always fatal. The exposed wound inevitably became infected. Lister applied dressings soaked in carbolic acid directly to the wound. He changed them regularly, always using the antiseptic solution. And he waited. 6 weeks later, James Greenlees walked out of the hospital on 2 healthy legs. Lister continued his experiments. Between 1865 and 1867, he treated 11 more cases of compound fractures using his antiseptic method. 9 remained free of infection. Only 1 required amputation. Only 1 patient died from unrelated hemorrhage. In March 1867, Lister published his results in The Lancet. The numbers were extraordinary. In his male accident ward, surgical mortality had fallen from 45% to 15%. He had cut the death rate by 2/3. You might expect the medical world to embrace Lister's discovery. They did not. Many surgeons refused to believe that invisible creatures could cause disease. Others complained that carbolic acid was messy and time-consuming. But the deepest resistance was psychological. Accepting Lister meant accepting that surgeons had been inadvertently killing their patients for generations. The controversy lasted more than a decade. The turning point came in 1877, when Lister performed an operation that would have been unthinkable before. He deliberately opened a patient's knee to wire broken bones together, converting a simple fracture into an open wound, which had always meant almost certain death. The patient recovered completely, no infection, no fever. Within years, antiseptic surgery became standard practice. By the 1890s, surgeons had moved to complete sterility, sterilized gowns, gloves, and instruments. The age of butchery was over. Robert Liston died in 1847, just months after performing Europe's first surgery under anesthesia. He never saw the antiseptic revolution. That would make his desperate speed unnecessary. Joseph Lister lived until 1912, long enough to see his methods transform surgery from a death sentence into a routine procedure. He was celebrated as one of the greatest medical pioneers in history. The 300% mortality rate represents everything wrong with surgery before the revolution: speed over care, tradition over evidence, pride over humility. The surgeons who changed medicine were not the fastest or the most theatrical. They were the ones willing to question everything they had been taught, to accept that they might be wrong, to wash their hands. Today, surgical mortality is measured in fractions of a percent. But the lesson remains: medical knowledge is never complete. What practices that seem obviously correct will future generations look back on with horror? The Victorians taught us that progress requires humility. Robert Liston was the best surgeon of his generation. Fast, skilled, dedicated. And yet, by modern standards, his operating theater was a death trap. That is not a criticism of Liston. It is a reminder that expertise is not enough. You can be brilliant and still be wrong. Lister succeeded because he was willing to question the fundamentals. That kind of thinking is exactly what we need. In medicine, in science, in everything. Thank you for watching. I am Daniel Crawford. If you learned something today, subscribe and hit the bell. See you in the next one.